This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. And we now offer Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes if anyone is interested. This week, we are going to be discussing a medication for alcohol use disorder at hospital discharge. So how are you doing, John?
I'm doing really good. It's the end of the school year for me at my house. I have little kids, and there's also the end of gymnastics season today. So I had to take my daughter to her last gymnastics for the year, which is really nice for everyone. Get the Thursday nights back. So excited for the summertime to have a little break.
That'll be nice. Do your kids go to camp or anything, or do they stay home?
Oh, lots of camps, all types of things. Acting camp, which, it's interesting. My daughter she does all these sports, and she's only ever gotten stitches one time, and she fell at Annie practice and got a big laceration on her scalp. And then there was a 5-hour wait at urgent care. So I did stitches on her, and it was a very difficult experience for all involved. It looks great though. You can't even tell where it was. But Annie camp will get you, or Annie practice.
Oh, man. Yeah, we had to send our kids to basically whatever camp was available that we could get them to at the time. And I remember one of my sons scornfully complaining that we sent him to clay camp, which was supposed to be like ceramics camp at the arts center, but he just called it clay camp and refused to go back to pick up any of his final projects after they'd been fired.
It's like prison. We're going to make these wallets today.
Yeah.
I'm going to sell them.
That's what he felt.
It probably makes a mean pot now.
John, is there anything you want to share with our listeners in addiction medicine news this week?
Yeah, I thought it was really interesting. An article that I saw that was sent out from KFF Health News. It was called "Tribal Nations Invest Opioid Settlement Funds in Traditional Healing to Treat Addiction." And you're going to have to forgive me. I'm sure I'm probably going to mispronounce some of these tribe names, but they were talking about this Mi'kmaq Nation's health department had actually just invested a third of the money they received from the opioid settlements. They received $150,000 so far, and they actually invested the first $50,000 into these dome-shaped sweat tents that has kind of like cultural and medicinal significance to them and their tribe as a way of treating addiction. And it's interesting, there's like a lot of money that's being sent out regarding these kind of opioid settlement funds. And we often think of rural America, but we forget that really the highest per capita in terms of opioid deaths really is our Native American population. When you look at it per year, it ranges from 47.5 to 65.2 over the past 3 years per 100,000 patients death rate, which is almost like double that of like a white counterpart. And so like, even though they're receiving a lot of money, they're getting about $1.5 billion to Indian tribes locally here in the United States. That really kind of out of the total $50 billion settlement, it's actually somewhat disproportionate. So that was one way they're using it. They also talked about how other tribes, Broad Creek Indian tribe was spending $500,000 actually on a statistical software to kind of analyze kind of impact of opioid use in their community. And that's how they were going to use settlement money. And so I think it's interesting. It's certainly kind of like culturally significant to this group of people. Part of me also feels like I'm not sure how kind of evidence-based these treatment options are. It's a lot of money we're talking about. And, it's interesting that we're kind of allowing these settlement monies to kind of be spent however people deem fit, whether or not that's in line with current standards of care or not.
I think that is the interesting thing. When you were saying that, just because, we talk about research all the time, I was like, what's the data on sweat lodges, which I'm sure there is not. But it doesn't automatically mean it's bad. I mean, I think there is data on creating community to avoid not only treat addiction, but prevent addiction. And so efforts in that direction in these sort of most marginalized communities, I think probably will help. But yeah, it is interesting that all these different communities are given basically free rein to do what they want with the medication. And I mean, with the money, and it seems like it's just going to get wrapped up in local politics, individual desires. Like, it does make me wish there was a more comprehensive plan for all this money. But I am glad that individual tribes, if they really do feel that that would be helpful, that they are able to do some of that stuff.
Yeah, hopefully they use the remaining funds they received to kind of incorporate some kind of like evidence-based practices that align with their unique culture to promote recovery in their communities.
I'm interested to see where all this money goes, and what, if it's spent on, will it Will these efforts really make a difference?
How about you? Anything you've been reading that's interesting?
So I read some super depressing articles. One that really hit me hard was in JAMA Psychiatry, and it was about children in the US who've lost parents to drug overdose. Because, of course, many of the people who die of drug overdose are parents. They're young and they leave behind young children. The author said that 321,566 children lost a parent during the 10-year study period, which was 2011 to 2021. And the number increased from 27 per 100,000 at the beginning to 63 per 100,000 10 years later in 2021. So more than doubled the percent of children who had lost a parent. And they also found significant disparities by race. Like you were saying, the rates were particularly high among Native Americans and Alaska Native peoples. I just see this affecting my patients. I don't treat children, so I don't see children who've lost parents, but my older patients who are grandparents, I see that affecting them a ton. I know many grandparents who are raising grandkids because they've lost a child to addiction. I looked up some data from the Census Bureau and the Bureau of Labor Statistics. They said that in 2021, there were an estimated 6.7 million grandparents who were living with a child under 18, and 2.7 million of them were responsible for most of the care. So, in terms of kids, that's 3.2% of all children in the US are being raised primarily by a grandparent. And then in terms of the grandparents, 1.1% of adults over age 55 are raising a grandchild in our state in Pennsylvania, which is a little higher than the national average. So, more than 1 out of 100 of our older patients is raising a grandchild. And it's really difficult when I see my patients doing it. These children are often traumatized. They have a strong family history of substance use disorder. The grandparents don't necessarily have a lot of resources, both, personal and parenting resources and, money type resources. Sometimes it goes well and sometimes it doesn't. I have some patients who, especially in my opiate use disorder clinic, they actually feel like they were not good parents. They were neglectful of their own children due to substance use. But now that they're older, that they're in recovery, they're stable, they're really actually consciously trying to make up for it by supporting their grandkids as their own children go through substance use disorder in a way that they didn't support their kids. It just made me really think. John, do you see a lot of this in your practice? These either children without parents or grandparents raising their grandkids?
Yeah, as you were talking about this, I can think of I have nice thing about family medicine is I take care of like multiple generations within a bloodline, and I can actually think of three families I take care of where I take care of the grandkids, the parent, and the grandparent, and that the parent is no longer here from overdose, and it's a really sad situation for the kids. Oftentimes, very tumultuous and difficult for them to kind of have guidance in their life, but I think the article also doesn't mention like the trauma to a parent to bury a kid, right? I think that's hard to not only be raising a child then, but also to have lost your own. They're hard visits and not super happy endings and most of the time when we talk.
Yeah. Well, and it's these sort of secondary consequences of the overdose epidemic, not just all the people we've lost, but the havoc it wreaks on their families, their children, their parents, their workplaces, their communities when so many young people die. So, on that sober note, here we are trying to fight substance use disorder with knowledge. Do you want to tell us about this article?
Yeah, so like I'm super excited about this article tonight. This is kind of like a dream for a passion project at our local hospital with this. So I actually want to use this when I have some discussions with some other administrators kind of coming up here. But the article is called Outcomes After Initiation of Medications for Alcohol Use Disorder at Hospital Discharge. It's from JAMA Network Open from March 2024. So, a little bit of background: alcohol use disorder affects 29 million adults in the US with an economic burden exceeding $250 billion annually. Alcohol use disorder is the fourth leading cause of preventable mortality in the US, resulting in over 140,000 deaths annually. Guideline recommended treatments include behavioral interventions and medications for alcohol use disorder, like naltrexone, acamprosate, and disulfiram, all of which are approved by the FDA for treatment of alcohol use disorder. Despite these recommendations for incorporations of medications, less than 2% of US adults with alcohol use disorder received medications for alcohol use disorder in 2019. I think kind of a particularly striking thing that I learned about when I was studying for my boards initially as a resident, I remember they had like a question and they showed that like 90 some percent of people that took the question got it wrong. It was like a mix up question. It was like, a person comes into your office and it was a vignette about that they're basically had alcohol use disorder. What was your recommended treatment? And almost no one picked the medication. Everyone picked AA. It was like 90 some percent of people. And that was like family physicians. So I think there's a lot of opportunity here for incorporating these medications into kind of standard of care, but also how we view the treatment of this disorder. Evidence from randomized controlled clinical trials support the efficacy of medications for alcohol use disorder in reducing drinking, particularly naltrexone and acamprosate. Naltrexone is shown to reduce the return to any drinking in heavy drinking, while acamprosate reduced return to any drinking among abstinent patients. Disulfirin's efficacy is limited, but is recommended under special circumstances. Certainly not a first-line medication for most practitioners.
Have you ever prescribed disulfiram?
I have not for alcohol use disorder, but I've done an off-label for cocaine use disorder.
Did it work?
50-50.
I have never prescribed it.
I have one girl that right now I'm working with she's really struggling, and she actually is requesting to switch over to this. So I may have my first one for alcohol use disorder coming up, but certainly, I don't know. I think most people, the idea of just getting sick from a medication, I probably would stop taking the medicine.
Right. It's
I think that's what the data would show.
hard to force yourself to take medicine that makes you sick.
Yeah. Hospitalizations are crucial for alcohol use disorder treatment engagement, with post discharge medications for alcohol use disorder initiation being a Joint Commission quality measure. However, despite all these things, medications for alcohol use disorder initiation post discharge among Medicare beneficiaries is incredibly rare. Reasons for underuse include limited knowledge of effectiveness and lack of training in the topic by our inpatient providers. Few studies have examined outcomes associated with medications for alcohol use initiation at hospital discharge. So, kind of before we get further along here, do you feel like what's your kind of been experienced in the past? And I know you don't do inpatient medicine anymore, but you at once upon a time you did, and we were redeployed during COVID. So, how do you feel about this as an area of opportunity?
Well, it's a huge area of opportunity, and actually, I am participating in our intern boot camp. We have our new interns coming in about 2 weeks, and one of the topics that the interns themselves, our new interns, said they wanted more information on was addiction medicine. And so when I've been writing my intern boot camp materials, one of the things I put was you got to put the substance use disorder on the medical problem list. And then you have to look up the most effective treatment. And then you have to put that under your plan and do it. I think sometimes they view alcohol use disorder in the same place you would put, I don't know, like the patient complains their heating bill is too high or things that are annoying and difficult, but not something that you as the doctor would be involved in. They sort of feel alcohol use disorder and other substance use disorders are in that category. And I'm trying to tell them put all of the substance use disorders on the problem list and then put down what your treatment is because all of these have treatments. So I'm trying to spread the word.
So the clinical question here is the initiation of medications for alcohol use disorder at hospital discharge associated with 30-day clinical outcomes among Medicare Part D beneficiaries? It's particularly looking at all-cause mortality and return to hospital within 30 days of discharge. So, methods, the study design, this was a retrospective cohort study of 6,794 unique patients presenting for a total of 9,834 alcohol related hospitalizations in 2016. It was looking at the effects of discharge initiation of medications for alcohol use disorder on 30-day clinical outcomes. The study utilized basically a randomly selected 20% sample from the Center for Medicare and Medicaid, CMS Administration, and Pharmacy Claims database from the end of 2015 to the start of 2017. Like we said before, the study population was 6,794 unique Medicare Part A, B, and D enrollees with continuous coverage before and after cohort entry, so after the prescription for the medication. They defined exposure as discharge medications for alcohol use disorder initiation, mostly through pharmacy claims data. So basically, this was not inpatient initiation per se. It was kind of a fill at a pharmacy afterwards. And they did basically naltrexone, acamprosate, and disulfirin within 48 hours of discharge. So they included anyone that had a receipt of the exposure, anyone that had an acute care alcohol use disorder related hospitalizations. That could be a primary or secondary problem related to the acute hospitalization. It could be whether it was a medical or mental health disorder as well. So it could have been a medical or psychiatric admission. And the patients had to be discharged to the community. So basically, if you went to like a skilled rehab facility or inpatient unit, that was not going to be included because it wouldn't hit that 48-hour outpatient fill criteria. They excluded Medicare Advantage enrollees, mostly because they didn't have the data for that in terms of administrative claims. Patients on Medicare solely for hemodialysis were excluded, which was actually not many patients when you look at it. I don't know the number off the top of my head, but it was under 50 total. Patients with contraindications to naltrexone or acamprosate, if you had a true contraindication, you were excluded from the trial. And patients receiving medications for alcohol use disorder prior to hospitalization. So this is purely just assessing not continuation of the medication, but kind of effect of that start at that opportunity in the hospitalization. Primary outcomes were composite all-cause mortality or composite return to the hospital within 30 days of discharge. So they counted as a hospitalization or just an ED presentation and evaluation. Secondary outcomes were all-cause mortality, return to the hospital within 30 days of discharge, so hospitalizations or the ED evaluation. So these two were separated, no longer a composite outcome. And then they also looked at outpatient primary care or mental health follow-up, which I think is a cool surrogate marker as an outpatient PCP as well. Do these patients follow up with us to kind of continue treatment afterwards? They did covariate analysis as well, looking at multiple sociodemographic variables: age, sex, race, ethnicity, census region. They did Medicaid dual eligibility status. So basically, if you're eligible for Medicare and Medicaid, you are most likely disabled. And that was like a surrogate marker of lower socioeconomic status. They did disability status. They also did clinical factors like medical comorbidities, psychiatric comorbidities, previous use of medications for alcohol use disorder. So basically, if you use medications 3 months to a year beforehand, they kind of reanalyze that. Healthcare utilization in the past. They looked at how often we come to the hospital or the emergency room, previous behavioral health treatment between 30 days and a year. So are you a frequent flyer for our behavioral health services? They looked at various hospitalization factors like primary diagnosis at discharge, whether it was related to kind of a medical issue, alcohol use disorder, a mood disorder, mental health diagnosis. They did the Elixhauser Comorbidity Index to kind of assess kind of what other comorbid conditions patient had and compared to one another. They looked at psychiatric involvement in the hospitalization, as well as actually addiction medicine consult during hospitalization, and then patient-directed discharge status. They tried to analyze and kind of equalize the groups looking at these covariates. Statistical analysis involved propensity score matching, modified Poisson regression, and sensitivity analysis, all accounting for those covariates. Any questions about the study design before I go into the next part?
No, it seems pretty clear. Just to be certain, it was only for 30 days after discharge, right? That they looked at mortality and readmissions?
Yes, that's all looked at for this trial. This is relatively short-term outcomes.
All right.
So is this trial valid? Kind of looking through it, the study was supported by research grants from the Institutional National Research Service Award, Massachusetts General Hospital Division, Agency for Healthcare Research and Quality, National Institute on Aging, and Mass General Hospital Research Scholars Program. So no industry bias there. The authors had multiple financial disclosures, all of which were nonprofit organizations, which really should limit bias. So, LOSA Health, American Heart Association, American College of Cardiology, USD Prescribing Research Network, and Boston Claude D. Pepper Older Americans Independence Center. So, no big pharmaceutical interest here. It was a retrospective cohort study from a large CMS database, so a lot of value there. Although not being a randomized controlled trial, it's kind of tough to truly determine the relationship and whether or not there's causation that could be accounted for this, especially since it's not blinded, not truly randomized. It's kind of all comers. Hopefully, the large sample size kind of buffered that out a bit. Like I said, large sample size, 6,794 patients, almost 10,000 alcohol-related hospitalizations. So a lot of N there. So that's kind of very good, kind of smooth out some of those results. The study was limited to Medicare population. So basically, this is an older and disabled population. I think it does limit generalizability of the study for the most part. I think that a lot of the frequent flyers that I take care of at the hospital regarding alcohol use disorder related complications, they tend to be kind of a younger cohort. We'll get into numbers specifically, but I would say that this trial might be a little bit on the older end.
Do you think that it's significant that they didn't look at Medicare Advantage? Because I always view those as a slightly wealthier population.
I would think so. I mean, I think as they kind of talked about, I don't think I've gotten that yet, but certainly the Medicaid dual eligibility patients, which kind of, like I said, surrogate marker of lower SES status is the majority of these patients. We'll find out here in a second. So I think the outcomes would be different. One thing that's very interesting is, and I think this kind of reflects the true nature of the problem, is there's really a very small exposure population here. So only 2% of these patients actually receive medications for alcohol use disorder during this time frame. And actually, that sounds super low, but it actually kind of tracks exactly with other studies for national trends. So 2% is kind of the number here and kind of in the literature prior to this. So a huge area of opportunity potentially. There's always unmeasured confounding bias, although they attempted to adjudicate this as much as possible with one of these large database trials with the covariate analysis. One thing that always kind of is tough, and I see this more and more, mostly to bore your mind out with the administrative end of my job at the hospital, but we do notice we're judged a lot on what's called a geometric length of stay at the hospital is right now, which is basically telling us like how long a person should be in the hospital based on how sick they are. And that's totally dependent upon coding. And if you actually enter the codes every day when you're submitting charges, what we found, at least locally, and I'm sure this is kind of nationally, is like people stop entering codes at some point. So it may be that a lot of these patients, there's other patients as well that had alcohol related hospitalizations that weren't picked up in this trial because maybe that wasn't one of the leading diagnostic billing codes that was kind of used for capture here. The study duration, I think, might have been a little too short to demonstrate mortality. Like, we'll get to that in a little bit, but there wasn't a huge effect on mortality. But 30 days, I think, is a relatively short period of time for a condition that tends to take lives over decades of use, not typically a very hyperacute period like opioids do. The author critiques this themselves, and I kind of agree. I think that if anything, if they were to kind of extend the time period, I think they would find more of an effect. Interestingly, they talked about capitated inpatient payments don't really allow them to identify IM naltrexone. So some hospitals, including the hospital I work for, we do IM naltrexone for select patients. It's interesting that this is the most evidence-based yet least utilized medication for alcohol use disorder. So we couldn't capture like our best tool in the toolbox. Also, we were unable to identify patients who received plus or minus adjunct non pharmacological therapies like behavioral health interventions or 12-step facilitation. And I know that we often talk with kind of our patients with opioid use disorder, how medication, kind of standard of care, often has the most efficacy. I find, at least anecdotally from my experience, that for alcohol use disorder, you really probably need a combination treatment plan. Most of the time, just a medication only approach doesn't often produce the results, at least I haven't seen, that patients desire.
Well, I think that's, this is a bit of a digression, but I think that's part of the reason these medications aren't used as much as they would be otherwise. They're just not as effective. I was recently talking to a patient and she's like taking all the medicines for alcohol use disorder. She's like, they're not working. I'm still drinking. And, unlike buprenorphine, where I had, 5 minutes later, I have a patient who says, like, I was horrible. I couldn't stop using fentanyl. And I haven't even thought about it since I took my first dose of buprenorphine. It just doesn't work as well. So you do need, I would think, more of a combined approach with multiple, therapeutic modalities, medication and therapy and behavioral change.
I think this is where like also like a lot of upfront counseling is helpful. Most of the data for these are not for buprenorphine. A lot of it's like negative urine drug screens, like abstinence approaches. That's not a ton of the data for these medicines, right? These are like decreasing binge drinking days, decreasing total volume of drinking. So I think that they need to know that ahead of time, or else they just feel defeated.
Right. Setting expectations.
Yeah. So, what are the results here? So, population, there were 6,794 patients, 9,834 alcohol related hospitalizations. The median age was 54 years old, so older middle age. Gender distribution, most were male, 67.4%. Most were white, 71.8%. Most were Medicaid dual eligible. So it's 70.3 and 76.3%, depending upon which group you looked at. But overwhelming majority were these dual eligible patients, which kind of reflects many things about the difficulty with treating this population and also kind of how it impacts our healthcare system at a whole. Most had an anxiety disorder, so 70.3 and 76.3% based upon the group. Most had a depressive disorder, 88.2% and 93.8%. Most also were smokers of tobacco, 51% and 66.4% between the two groups. Most had seen a primary care physician in the past 12 months, so about 54% and 60% in the two groups. And most had not had a mental health visit in the past 12 months, so 20.4% and 21.9%. So, I think that, just the population itself and some of that demographics reflects the opportunity, at least how I think that alcohol use disorder really falls into the primary care spectrum more so than than the behavioral health, although there's a lot of collaboration there, right? A lot more contact. So, discharge medication for alcohol use disorder initiation. So, 2% of hospitalizations. So, out of that almost 10,000 hospitalizations, only 192 resulted in initiation of a medication for alcohol use disorder that was identified. Not surprising. Naltrexone was the most common at 58.3%. Acamprosate was the second most common at 27.6%. And disulfiram was the least at 16.7%. I actually find that 16.7% received disulfiram incredibly amazing. That's a very high number from what I was expecting.
Yeah, that's a little high.
Covariates before matching differences were observed in prior psychosis. So, if you had previously had psychosis, that decreases your chance of receiving a medication for alcohol use disorder at discharge. Tobacco use disorder. So, if you smoked, you had a lower likelihood of receiving medications for alcohol use disorder at discharge. And actually, if you had a remote history of medication for alcohol use disorder, it actually increased your chance of kind of reattempting another trial of medication. After covariate matching, everything really balanced out. So, primary outcomes. So, in terms of this composite outcome of 30-day hospitalization or mortality, 49.3% experienced the primary outcome. So, all cause mortality or return to the hospital within 30 days. 25.5% of outcomes occurred in the medication for alcohol use disorder initiation group versus 49.7% of outcomes in the group that did not receive medication for alcohol use disorder. So, substantially more of these composite outcomes occurred in the group that did not receive treatment at discharge. Discharge medication alcohol use disorder initiation was associated with a 42% decrease in incidence of the primary outcome, so that composite score. So, relatively large decrease here for a relatively small subgroup of the population. In terms of secondary outcomes, discharge for medications for alcohol use disorder initiation was associated with decreased incidence of all cause ED visits. So they did an IRR of 0.54, all cause return to the hospitalization with an IRR of 0.56, and all cause readmission with an IRR of 0.42, with really kind of representation for emergency department evaluation being the number one driver of kind of this improvement between the two groups. There was really no significant difference in mortality. I think this does reflect 30-day period was probably a little short for that outcome. And sensitivity analysis showed that these results were consistent across multiple different reanalysis, supporting the association between discharge medications for alcohol use disorder initiation and improved outcomes. I love for our live journal club showing graphs. I wish I could do this with this one, but they actually have an amazing graph for this one. It really shows just a bar graph showing comparison of the two groups and how they performed. And really, it's pretty, when you see them next to each other on paper, the improvement with the medications at discharge is pretty astounding. So, substantial differences between the two groups and composite all cause return to the hospital or death, all cause return to the hospital, all cause ED visits, all cause readmission. And then you look at other markers like alcohol specific related return to the hospitalization was lower in the group that received treatment. Alcohol related ED visits was lower. Alcohol related remissions was lower. And actually, there was a slight increased likelihood that patients would follow up with their primary care provider at discharge. So, all kind of very positive stuff.
The graph is very pretty. I'll post it on social media if anybody wants to either follow us on Instagram or join our Facebook group. I will post John's favorite graph when we release this episode.
Yeah. Will the results here help me in patient care? I'm a family medicine doctor that practices inpatient medicine, and oftentimes, like my other colleagues in family medicine, often practice inpatient. I kind of am the curbside, like addiction consult for patients. We often talk about kind of using some of these as areas of opportunity. We always have a couple patients, sadly, on the service every week I'm on that are on a CWAP protocol for kind of alcohol withdrawal. I think that these inpatient hospitalizations are really great times to offer treatment, especially for the people that come into the hospital sometimes, 20, 30 times per year with an alcohol related complication. I've always kind of offered these medications in the hospital. Sometimes people take me up on it, sometimes they don't. I think my one claim to fame when I retire will be I was the first one to give the IM naltrexone in the hospital, which apparently wasn't approved by the P&T committee for another 2 years, but I was given it for 2 years before then. And I think it can be very useful for patients that just want to curb their drinking. So a lot of times, patients that are hospitalized for these alcohol-related hospitalizations, they have very high volume drinking. So, it's not uncommon to hear someone that drinks 20, 30, 40 alcoholic beverages a day. And the medications, like I said, they're not typically abstinence medications. They're often not interested in formal inpatient treatment or counseling, but they do curb or decrease volume and frequency of heavy drinking days, which sometimes can keep them out of the hospital for longer periods of time. So I think it is an opportunity from that regard. Ideally, they would kind of engage in a comprehensive recovery program, but you have to work with what you got. So I think that this study, although not a randomized controlled trial, kind of large database trial, it does kind of reinforce my thoughts about the topic from the start, that this is definitely an area of opportunity. And I really, like I said, at our hospital, I really would love to get this off the ground. If I can find a group to recruit to also kind of buy into this being a great asset for our organization.
I guess the one question I have, John, and this is what jumps out at me because it's not a randomized controlled trial, is I talk to a lot of patients about their drinking because I screen for alcohol use disorder during all my, annual visits. And many patients drink too much and know they drink too much, and yet they decline treatment and decline medication for alcohol use disorder. So I feel like the people who accept prescriptions and fill the prescriptions for medication are a different group from those who don't. So when you are asking your patients who have alcohol use disorder, do you want treatment? Do you want medication? What's the uptake like?
In the hospital,
Yeah, like a discharge.
I mean, that's the best place for it, right? They're in a low, right? They're in the hospital. Oftentimes, they have to be there for 48 to 72 hours. The alcohol's out of their system. There's a depressant effect of that withdrawal. They feel bad. They want to change, right? That's probably I hate to use the term, it's cliche, like they're low, but it is a low point for them, right? I
Mhm.
think it's embarrassing to be in the hospital. I think that there's a lot of extrinsic motivations that, I mean, we're not trying to make them feel bad, but I think that they are receptive to that. And I don't know. I think it's different. Like in the office, when we screen for them, we kind of screen them if they're at risk, right?
Mhm.
It and so like I have lots of people, I have lots of like construction workers and truckers that they tell me they drink like 16, 18 beers every night, and but they don't have DUIs, they don't have any issues with their relationships, they're still working. And so like they're like unhealthy drinking, but they're not like alcohol use disorder yet.
Mhm.
But I think it's hard to admit when you're in the hospital that this hasn't impacted other domains of your life, right?
Right, it's pretty clear you have a problem.
It's the same with opioids, right? I mean, the chronic pain patients are tough sometimes because they don't have the insight yet that maybe they're in a bad place. But like when they come to my addiction clinic, they've already come to that at some point. And so they're more receptive and it's a different starting place.
Right. I guess that's a good point. You're starting from a different point with people who are in the hospital for an alcohol-related hospitalization. I think it was a great article. Good luck getting your alcohol use disorder consult service up and running.
It's not going to be a consult service. I just need people to buy in to prescribe.
They just got to prescribe naltrexone. That's all you want. That's all you want.
Yeah, that's basically it.
Well, thank you for presenting that article. I think it's really great, and you'll have to update our listeners on the success of your personal initiative as you achieve it. So, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is a conversation, and we want to hear what you have to say. So, please send us your comments, and we will include them on a future episode. You can email us, you can put it on all the social medias. We have a Facebook group, and if you're listening on Spotify, there's a little field right on the podcast itself where you can put your comments in about the article. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Aaron McHugh, CME support from My Cares. We are produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.